dear participants. I'm very happy to welcome you on behalf of the ERN-EuroBloodNet coordination team. Today we are going to see with the expert physician member of EuroBloodNet Congenital Dyserythropoietic Anemia I and Congenital Dyserythropoietic Anemia II. Specifically today we will have a general introduction on CDA including epidemiology, led by Dr. Noemi Roy, who is consultant hematologist at the Oxford University Hospital. Then we will have with Dr. Paola Bianchi, we will address the diagnostic aspects. Paola Bianchi, she's head biologist and working at the hematology unit in the Ospedale Maggiore Policlinico in Milan, in Italy. Then we will see clinical aspect with Dr. Roberta Russo. She's a researcher in medical genetics at University of Naples, Federico II. And finally, again with Dr. Noemi Roy, we will address the current and future therapeutic perspectives. So, dear audience, please welcome with me Dr. Noemi Roy for the first topic of the session. Thank you very much.
Thank you. And thank you everybody for being here. It's such a pleasure to see so many people interested in CDA. And well done, Mariangela, for all your pronunciation of congenital dyserythropoietic anemia. I was very impressed for someone who's not a clinician. So I'm going to start with a general introduction. And I'm going to try to speak slowly because I know that you're all coming from different places. And thank you for those of you for whom English is not your first language. It's very nice that you can join us. So one thing that's always a little bit difficult to do a patient webinar is that everybody's coming at it from a different place. You'll have different diagnoses. Some of you won't have a really very clear diagnosis. You might have been told it might be CDA, it might be something else. We don't know quite what the subtype is. And really, it has a horrible name, congenital dyserythropoietic anemia. I mean, even most doctors can't pronounce it properly. So I thought just to start with to say, well, what does it even mean? So congenital means you're born with it. But of course, not everybody will have been diagnosed as a baby. Some people will be diagnosed with CDA in adulthood or as a teenager. Dyserythropoietic just means that the shape is abnormal. And so here I've put some dyserythropoietic carrots. You can see that you can tell that they're carrots. You can tell they want to be carrots and that they want to do the job of a carrot, but they're not really what you would expect the shape to be. And essentially the red blood cells have got a shape that's not what we would expect it to be. And then anemia, I think, is the one we would all feel very comfortable with, which means not enough red blood cells. And in terms of epidemiology, well, how common is CDA? Well, that's a bit of a silly question, how common it is. It's better to ask how rare is it? And it's a bit like, I'm sure many of you will have been told you're unique, or you have a very rare disease, you're very special, very few people are like you. So that's why I put this 4-leaf clover here. And these are some numbers that were published a good 10 years ago. And in the first one is CDA I, and in the second one, in the bottom one is CDA II, with the number of patients that have been reported to have these conditions. But of course, we can't say, first of all of these numbers will have increased in the last 10 years, but also we can't say that that we will know about every case. And if talking about rare diseases, what do we mean? And I took this slide from EURORDIS. We know that each rare disease, when we say rare disease, it affects fewer than 1 in 2,000 people. But there's a lot of different rare diseases, and there's over 6,000 different rare diseases. And altogether, we estimate that 30 million people are living with a rare disease in Europe. So sometimes it's helpful to think that although you have a rare disease, and you may not often meet other people with this rare disease, there will be lots of other people living with other rare diseases who will be facing a lot of the same challenges that you're facing. And I thought it would be nice to try and visualize, what does that mean? What does rare really look like? And a rare disease is one that's described as fewer than 1 in 2,000, but really CDA is an ultra rare disease, which means it affects fewer than 1 in 50,000 people. And just to give you an idea, I've got this little set of slides to visualize with your eyes how rare is 1 in 50,000 or even fewer than that. So in this picture, you've got a square that's made up of 10,000 dots. And when we're talking about CDA, we're talking in the range of 1 in a million. I'll come back to that, but I just wanted you to see, what does a million dots look like? If this is 10,000 dots, what does a million dots look like? And I'm going to scroll through. A million dots is this, plus 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 this, that we've just looked at a million dots. So when we're talking about CDA and saying it's probably about 5 people per million, suddenly you think of all those dots and you think only 5 of those would be CDA patients, and all the other dots would be people who don't have CDA. But we know that it's probably underestimated. And the reason for that is we've not been looking for these cases. In the past, we used to find these cases when the people had fairly severe anemia, and we would start an investigation. And we didn't have very good methods for diagnosis. But now we're doing more and more genetic testing. So in the UK, I don't know about other countries, but in the UK, it's now become very easy to get a genetic test. And we're doing it much sooner when even a pediatrician is thinking that a child has an unexplained anemia. And we're finding more and more cases. But interestingly, we're also finding that adults who've not known that they had anything wrong with them, as they're getting older and they go and see the GP to say they're very tired, they found to have anemia, suddenly we're finding people who are milder, who didn't present as children, but who turn out to have CDA that they didn't know about until they were much older. I wanted to do a little bit of an introduction about what exactly is happening in the bone marrow. So we know that in the bone marrow is where we all make our blood cells, our red blood cells to carry oxygen, our white blood cells to fight off infections, and our platelets to stop us having blood clots. And all of these cells start off in essentially things, they are like seeds. They're called stem cells, hematopoietic stem cells. And these stem cells that are like seeds can grow and make more and more and more mature red blood cells until they're ready to come out of the bone marrow and into the bloodstream. And some of you will know about the reticulocytes or retics. These are red blood cells that come out of the bone marrow, and they're just a little bit young. They're not quite ready, but they're almost ready. This is what it looks like in the bone marrow. But let's imagine that instead of blood cells, we were making flowers. So we would start off with very immature flowers, just the bud. And as they become more and more mature, the flowers are opening until they're ready to do the job of a flower. Now, with this flower analogy, let's look at a normal bone marrow. I showed you this slide, which is like a line, but in fact, it happens more like a pyramid. So you start off with a few of the buds, but as they become more mature, the cells grow and expand until you have lots and lots of mature cells. And these are the ones that are ready to go and carry oxygen in the bloodstream. But when you have CDA, whether it's CDA I, CDA II, 3, 4, 5, 6, or CDA that we don't have a type for, your red blood cells are not making, your bone marrow is not making enough of the mature red cells. So you can see you have very few of the really nice open flowers. But what happens is the bone marrow fills with all of these immature ones because it's trying so hard to catch up to the anemia and to make these cells, even though it doesn't manage properly. I'm now going to hand over the presentation to Paola, who's going to talk to us about the diagnostic aspects.
Okay, thank you for attending, and I will talk about the diagnostic aspect. Okay, and starting from what Noemi told, I present you in the cells that are indeed involved in this disorder, that are some immature red cells that usually are in the bone marrow, but in some cases in CDA, we found also in blood, and the immature and mature red cells. What that we have to know is that red cells are originated in bone marrow, run for about 120 days, and they run and they are destroyed at the end of their life in the spleen. And in this period, they run for about 500 kilometers. So a longer journey in our circulation. I'm less romantic than Noemi, and I imagine the blood marrow as a very good factory that produces a very good product that in our case is a car, but this is like red cell. And there are some conditions in which we have different and some problem in the production. So we have a lower production, and we are in the case of red cell aplasia, but the curves are very perfectly performed. And we are in the case, as we saw before, in some curves that are incomplete. And this is our case, in the case of Dysérythropoïétique anemias. But then there are other disorders. For example, we can have some curves that are defective, and they are not perfectly performed and produced. And this group of disorder group a very, very large group of different disorders. That is, for example, thalassemia, or the red cell disorder, or defect of metabolism. And all these disorders are really very heterogeneous. And then finally, there is another condition. For example, the factory produces very good cars, but there is some external agents that destroy them. This is a case of acquired disorder, as in the case of autoimmune hemolytic anemias. Which is the problem? That all these disorders are there and have also the same clinical picture. So most of them display anemia of variable degree, jaundice, hyperbilirubinemia, splenomegaly, and in some cases, iron overload. So you understand that when a patient has this kind of clinical picture, it's very difficult to find which is the real true diagnosis. So the challenge of the diagnosis in CDA, together with the rarity of this disorder, is to discriminate among this large group of disorders. We have some markers and some parameters that can help us. And a group of parameters, laboratory parameters, are the marker of hemolysis. And in particular, we have reticulocytes that are usually increased because the bone marrow in hemolytic anemias, the bone marrow try to compensate the defect, whatever is the cause, with increase the number of the cell. We have unconjugated bilirubin because it is a sign of hemolysis, consume aptoglobin, and increase LDH. I'm sorry, we lost some arrows, but okay. And this, how these parameters are altered, we can know if our kind of anemia is inside of the spleen, is extravascular, so the cells are destroyed in the spleen, in particular in chronic condition like CDA, or is intravascular hemolysis like in acquired hemolysis. Anemias. And so we have some initial information. When we have a suspect of a CDA, when for the reason we talked about before, the number of reticulocytes is not increased in a proportional way to the degree of anemia. So we expect that based on anemia, we have a rise of increase of reticulocyte number, but in the case of CDA, the reticulocytes are low. Then the second aspect is that we can find some bone marrow abnormalities, as Noemi explained. And the third point is in this disease, sometimes, often we found also a deposition of iron. So we found iron overload. This is due to ineffective erythropoiesis, so altered red cell production, and the hemolysis. But then but when we have to do the diagnosis, we cannot look only and just to laboratory parameters, but also to other characteristics. In particular, the transmission, because all these diseases, CDA I and CDA II, both have an autosomal recessive transmission. So often we don't have information in the family because the parents are usually healthy carriers. Then we look at the clinical picture in CDA, but we'll see later. We will have also other non-hematological manifestations that can suggest the presence of CDA. And then we look at the blood count. We have anemia at increased red cell volume. And then if we look at the bone marrow examination, we saw here, you can see by the arrow, some abnormal immature cells that are not divided very well. In this case, we found this internuclear breach that is typically found in CDA I. But if we look in more detail and we use an electron microscopy and we look exactly in the cell, this is an erythroblast, and this is darker is a nucleus, we see that in the nucleus we have some pore, and the heterochromatin, so the material darker, is distributed as we see here, Swiss cheese. So there is a little fantasy, but this is typical distribution that in CDA I. But what that at the end give the correct diagnosis and the final diagnosis is the molecular investigation. In fact, we now know for most of the patients which are the genes involved in this disorder, in particular CDA and 1 for the, and C15O41. And this is a schematic representation of the gene. And in black, you see how many mutations and different abnormalities we found in this gene for CDA I. And also in this second gene, we find at the moment 5 different mutations. So each patient has one homozygote or 2 different mutations in this gene. And this confirms the diagnosis. Why this gene determines this kind of disorder? And we use this very nice cartoon in which the gene involved in CDA in general are represented. You can see here codenine 1 and C15O41 that interact and act in transcription of DNA and the proteins, but also, if you can see here, they interact in the cell division process. So they can explain why we found immature cell, because cell cannot arrive to the final division. But which are now the typical feature of CDA II. The transmission is the same. We don't have other extrahematological signs, so just anemia, but is heterogeneous. And when we look at blood, what we saw in the bone marrow, we find, and sometimes also in peripheral blood, binucleate or multinucleate erythroblasts, so other immature red cells, not fully divided. If we look in the more precision in electron microscopy, very typical of CDA II, we found this, you see a little line, white line, that are membrane that are run in the inner surface of the cell. And the other aspect, if we look at the membrane in the red cell, the membrane proteins, we found that, I don't explain this, but some proteins, these dot are proteins that run in electrophoresis, are different from the normal control. They lose this tail of glycosylation, and this is typical of CDA. And I usually show this because this test, SDS page, is usually used to diagnose a red cell membrane disorder that we saw before is a different disorder. But when we tested with this test, all the patients arrived with the diagnosis of erythrocytosis, we found indeed that 15% of these cases were indeed CDA II. So you see that many patients may have a misdiagnosis. And some years ago, the gene was identified. The name of the gene is CYC23B. As you can see here, the square and the circle are the different mutations found in the gene. So you see, also in this case, many different variants. And what's happened for the CDA II? This is very nice because CYC23B is a gene that interacts in the membrane inside the cell. This is an erythroblast. And the fact that this gene doesn't work very well determines the accumulation of this kind of membrane in the external surface. And this is what we saw exactly in electron microscopy. But then we see that CYC23B may also interact in the division, the cell division itself. So also in this case, we can explain why we have a retard and abnormalities in the cell division and the maturation of the cell. What is the new approach? Now with the new generation sequencing and sequencer, we are able to study many genes at the same time. So we can study all different genes in the same tube and to look in just one analysis all the different effects linked to the cell. And this is a very great advantage because improved very much the diagnosis and allow to make more precisely the differential diagnosis. And look at this. This is just an example. Look, these are different works, and these are the number of gene different studied at the same time, the patient. And look here, for example, this patient had an initial diagnosis of CDA, but then they were recognized as another disorder, a defect of metabolism. But of course, happens the opposite condition. So this new techniques really will improve the diagnosis. So this is my last slides, just to say which is the add values of molecular investigation. First, we don't have invasive technique and invasive investigation with, for example, bone marrow. The introduction of molecular testing, look at here, drop down the age at diagnosis. These are CDA II patient, and these are stratified for the age birth date, so many years ago. The diagnosis was really variable, but after the introduction of molecular testing, the diagnosis is done in the very early year of life and month of life. Which is also the advantage. We reduce misdiagnosis. This allows genetic counseling. increase of course the increased awareness of this disorder and pathophysiology, but also a precise diagnosis allowed to have access to new disease and specific therapies. So I thank you very much for the attention, and I introduce Roberta Russo that will talk about clinical aspects.
Thank you, Paola and Noemi, for this introduction. And during these few slides, I will briefly explain the main clinical aspects of congenital dyserythropoietic anemia. And as already described and explained in the previous presentation, CDAs are rare genetic diseases. They are also termed Mendelian disorders, because this means that they are caused by, as already listed, by mutation in a single gene. And these genes, when mutated, affect the process of differentiation and proliferation of the red blood cell of erythroid lineage. And this alteration account for some the appearance of clinical features as already presented. And the most common clinical features are anemia with some degree of hemolysis, reduced reticulocyte count, jaundice, splenomegaly. But beyond the common complications are also there is hemosiderosis, that is a relevant secondary aspect of CDAs, gallstones, and in 20% of patients we have transfusion dependence. From a morphological point of view, as already listened, in the bone marrow, we have these peculiar types of erythroblasts, such as the presence of these peculiar findings in CDA II, for example, presence of a double nucleated erythroblasts, or presence of 3 nuclei in the erythroblast. But we have another important feature that can explain the main signs at the clinical level of this anemia, and this condition is the erythroid hyperplasia. To understand the erythroid hyperplasia, we can imagine the normal differentiation process of red blood cells as a water tap, and that flow in a water hose, in a water tube. And during the normal process, we have the production of a lot of, at the end of the process, we have the production of a lot of erythrocytes that correspond to the spill out of the water in this picture. But in CDA patient, what happens? In CDA patient, we observe a block that is represented in this picture by the feet of this man on the water tube, and this block account for an accumulation of the water before the block that correspond to the accumulation of in the bone marrow of the immature red cells that are mostly, most of the CDAs termed polychromatic erythroblasts. And this is important. This concept is important to understand at least 2 main aspects of the clinical signs, clinical features in CDA patients. The first aspect, of course, is the occurrence of anemia, and also the occurrence of reduced reticulocyte count, because if we have a block in this step, we cannot produce, the bone marrow cannot produce an adequate number of reticulocytes, and this accounts for a reduction of hemoglobin level in the patient, and subsequently in a reduced oxygenation of the tissues, so increase of hypoxia, that triggers the production of erythropoietin, that is the hormone important, essential for the differentiation and proliferation of the red blood cells. And this hormone is produced by the kidney. So in these patients, in CDA II patients, we observe anemia with the reduced reticulocyte count, with the very high level of erythropoietin. Indeed, if we measure these levels in the serum of CDA patients, we can observe a very high level of erythropoietin compared to the normal reference range that is represented by this gray bar. However, despite these increased levels of erythropoietin, there is this level, erythropoietin is not able in these patients to increase the production of red blood cells because we have a block. And another important aspect related to this condition, that is erythroid hyperplasia, is the hemosiderosis. Hemosiderosis means the increased levels of ferritin, as we will see, and also increased the levels of transferrin saturation. And why we have this condition? Because these cells, these immature cells, produce some hormone and molecules, and among these molecules, they produce an important hormone that is termed erythroferron, or ERFI, that in turn regulates the production of this other hormone in the liver, that is epsidin, that is the master regulator of iron balance in our body. So in CDA patients, we observe this situation. We have a low level of epsidin and a very high level of ERFI in the serum samples. And this partially explain the observation of increased levels of ferritin and also increased transferrin saturation. Why it is important to analyze the iron balance and to look at this aspect? Because hemosiderosis in turns account for, may explain some secondary events and clinical aspects that are related to the iron accumulation, such as the problem related to heart, cardiomyopathy, or secondary diabetes, or hypogonadism, or hepatic dysfunction, and so on. So it is important to understand why we, in these patients, we observe increased tendency to iron overload, and why it is important to follow up this aspect during the natural history of the patient. And regarding the other component of this clinical spectrum of CDAs, we have to say something about the hemolytic component, because patients affected by CDA II may exhibit hemolysis and also jaundice, splenomegaly, and the secondary events related to this aspect. They may present the formation of gallstones. Splenomegaly rises by the fact that beyond the reduced production of red blood cells in this patient, we have also some production of red blood cells that are pretty much abnormal, so they are easily destroyed into the spleen, and this accounts for the enlargement of the spleen that is termed splenomegaly. The destroying of red blood cell increases the bilirubin levels in blood circulation, and this accounts for jaundice that can be observed at biochemical data as total bilirubin. And since we have an increased turnover of red blood cells, this bilirubin accumulates in the gallbladder and may account for the formation of gallstones. As already explained by Paola, there are several subtypes of CDAs, but more or less the clinical features of each subtype are pretty much similar. We have some differences, mostly from CDA type 1 and type 2 that are the most common forms. Regarding clinical features of CDA type 1, we have to know that this condition is generally characterized by anemia, that is generally microcytic. This means that the volume of the red blood cell is increased, and this anemia may range from severe form to from moderate to severe form, and generally it has a neonatal appearance. But also in this case, we may have the observation of jaundice, splenomegaly, and also in this case, hemosiderosis. And an important aspect related to CDA I patient is that the presence of morphological body abnormalities in approximately 10% of patients. And these morphological body abnormalities may range from skeletal malformations to syndactyly hands or feet, or absence of nails or supernumerary toes. Regarding the CDA type 2, that is the most common form. In this case, the onset of the disease is not properly neonatal, because on average we have an age of onset of symptoms approximately at 4 years. But as already stated by Noemi, in this case we may have a delayed diagnosis. So indeed the mean age of a diagnosis is approximately 20 years. Also in this case, the anemia is variable or variable degree, because it may range from mild to severe in a few percentage of patients. Generally it is normocytic. This means that the volume is normal, in the normal range. And also in this patient, in CDA II patient, there is a tendency to iron overload as attested by increased serum ferritin. Splenomegaly is another feature common for among CDA I and CDA II patients, and in this case, we observe a transfusion dependence in approximately 20% of patients. Okay, now I leave the floor to Noemi for the last part on current and future perspective, therapeutic perspective.
Thank you, Roberta. So what struck me so far by listening to everybody else's presentation is I've loved the different images, and I think it's really useful to see how different people think of it. And we've had in the chat somebody talking about having had CDA for a long time and only just starting to understand it now. And I think it's true that this is the kind of information that you may not need to receive once. You may need to receive this information many times in lots of different ways. So I really love the fact that there were different images that might work for different people. Okay, so I'm going to just talk a little bit about the treatment. I want us to have time to discuss at the end. For me, the most important thing is that the best treatment is a partnership, okay? Looking after somebody who's got a lifelong condition such as CDA is not about the doctor telling the patient, do this, do that, don't do this, don't do that. We have to work together as a team. The patients, you are all experts in your condition, and you will know more than anybody about your condition. And especially with a rare disease, what you have may be slightly different from what somebody else has with the same condition. So it's about seeing you as an expert in your condition. But you don't have all the information that you need to look after yourself. You will need the help of the rest of the team, and the rest of the team will be the doctors, but also the nurses. Sometimes there'll be it might be dietitians, or it might be some doctors that have a specialty, such as maybe some people will need endocrinologists or will need bone doctors, and also the role of the patient organization. So we really have to work together to give you the best treatment that you can. And there's lots of different options, and not every option will be open to every patient, but it's important to explore all of these options. So for example, I've put here somebody having a blood transfusion, and I think one of the participants in the chat was mentioning about being transfusion dependent. And some people will be with CDA will be having transfusions from birth. Others will have a few transfusions at birth and then not need them ever again. Some people would need a few transfusions at birth and then not need them for many years, and maybe during pregnancy or around the time of an operation would need a few blood transfusions. The importance of folic acid and eating, having a diet that's going to help your bone marrow to replenish is really important. And we've heard about the hard job of these red blood cells and how many kilometers they have to go through in their lifetime. And when you have CDA, unfortunately, your red blood cells need extra help. And that's where the folic acid and the diet will come in. Some people, as Roberta was really nicely explaining, will accumulate iron. And for those of you who are having transfusions, that's something that you're very used to, because you know that every time you have a blood transfusion, you will need to take the iron away from your body. But for some of you, the iron will be accumulating even without transfusions. And that concept of needing iron chelation, the drugs that take the iron away, not necessarily your whole life, but at certain points in your life, is going to be very important to prevent complications like cirrhosis or other iron overload complications. I've put a stop sign here because Professor Yolascon, who is on the call as well, did a very nice review of when is it useful to take spleens out in CDA and other red blood cell conditions. And really, it's very rare that we would recommend taking somebody's spleen out. There has to be very good reasons for recommending this operation. Now, I know that some of you will have had your spleens removed because that was at the time thought to be the right thing for you. And then you have lifelong antibiotics to take and vaccines. But it's not certainly nowadays something that we would be recommending. But of course, what everybody wants to know is if there's any specific treatments and if there's any cures. And the only specific treatment we have for any subtype of CDA is interferon alpha that's given for CDA I. And this is a drug that goes under the skin, usually once a week, sometimes more, sometimes less, depending on the type of interferon that's used. And it can be extremely helpful. Having said that, I know of some patients who've started interferon and felt worse with the side effects. Even though their hemoglobin came up really nicely, they felt worse because of the side effects of interferon and had to stop it. Now, I also know that some of you, nobody will have mentioned interferon if you have CDA I, and nobody's been offering it to you. And this is an important discussion to have with your hematologist. And I think I always want to remind patients that it's the right to ask the doctors and to question the doctors. If you want to know, there might be a good reason why your hematologist doesn't think it's a treatment for you, but it's worth asking and having that discussion. Is there any cure? Actually, that's the question a lot of people will want to know. What about bone marrow transplants? What about genome editing? And this is not something that we can discuss in detail today. We can maybe come into it in the discussion, but none of these will be a straightforward answer. Even bone marrow transplant, yes, there are pros, but there are cons to having a bone marrow transplant. It's not an easy decision. It will also partly depend on where you live, whether this is something that can get funded or not. And also we have to think about, what does the future hold? Can we wait for some drugs that are going to make a big difference and not go for one of these more extreme approaches, such as the bone marrow transplant? There are definitely some patients who've had bone marrow transplants. They've been published in the literature. We can find them. It's not necessarily clear who are the right patients to have this at the moment. I also wanted to bring up mental health, and mental health is something that's become very important to a lot of us during the pandemic. This is something that the general population, I think, has finally been able to talk about this a bit more. But when you've been living your whole life with a chronic illness, with a rare disease that has reproductive implications that you might pass on to your children, that you're always battling for people to believe you, that you may not have access to a specialist who has much time for you, that you have to deal with your own doctor not knowing anything about your condition. These are all issues that are really important to take on board. And certainly in the UK, we're very lucky because we're able to have more psychologists be involved in looking after patients with rare diseases. And then I wanted to talk about what's on the horizon. And some of you will know about some drugs, luspatercept and sotatercept, which are used for other types of ineffective erythropoiesis. So that's this idea that the bone marrow is trying really hard to make red blood cells. It's full of parts of red blood cells, but they don't come out properly. And these drugs have been helpful in patients with myelodysplastic syndrome and in patients with some types of thalassemia, in reducing the transfusion requirements, in possibly reducing the iron overload. And we really hope that we can use them in CDA. But it's not, we have to sort of discuss with the drug companies about this. So my last slides is let's work together. Let's work together to support the patients, to share knowledge and expertise. Let's learn from each other. I'm a doctor, but I can learn from the patients. I can learn from your symptoms. I can learn from some of the finding out what's worked for you, what hasn't worked for you. And then let's work together to lobby drug companies to fund research so that we can try and find, sometimes it's not even about finding new drugs, the luspatercept and sotatercept. It's about trying drugs that already exist and are already available for other conditions. I will now stop sharing and I hope we can have a discussion all together.
Thank you very much to Noemi, Paola, and Roberta. Thank you so much. We have received first questions and first very encouraging and warm comments on positive feedback. The first questions I have received privately. I am a CDA II patient with proliferative membranous glomerulonephritis. Following ketone therapy, I have seen the proteinuria worsen so much that I have had to stop treatment. There are other cases where the two diseases go together. How can I control the hemosiderosis? The treatment I tried was with XJade.
These are two different conditions. So these patients had a nephrotic syndrome. So it's not certainly related to CDA. So it's not a common problem in CDA to have a problem like a renal disease, like in this case. So, but nephropathies exist, and it could happen that you have also other diseases. So this is very important because the CDA, we have to learn that CDA patients are normal people, so could have the disease of all the normal people that could add some problems to the CDA condition, but are not related to CDA condition. So also the drug that she or he could use are the normal drugs for the treatment of CDA. There are no relationship, and also she could use XJade for iron metabolism.
You wouldn't worry about the effect of XJade on the kidney because you can't get proteinuria from the XJade, but I know some specialists will still give, you would still give XJade, yeah, even if there's, so I guess, I don't know who was asking the question, but it depends, sometimes it depends on the specialist you speak to, and I think that's one of the issues with a rare disease, is very difficult because you're not getting the same advice from everybody, but yeah, so if you're not, if your hematologist isn't somebody who really has that much experience with one of these rare diseases say, you can ask them, speak to Professor Ulascon, especially if you're in Italy, speak to Professor Ulascon, email him and ask him, because we have to share the knowledge like this. Yeah, but also, so actually we have a patient with CDA I and kidney failure. And again, it depends, as Professor Ulascon was saying, they can be two different things that in the same patient. Also, sometimes when you have consanguinity, where you have the parents are first cousins, you have you can have more than one genetic condition because of the similarity of the two genes. Yeah.
Thank you. So next questions. How many years should CDA patients need folic acid for?
I mean, essentially the answer is your whole life, but the other answer is we don't have any data, right? We don't have like a nice clinical trial that says if you take your folic acid, you do better than if you don't take your folic acid. It's one of these things where we assume it's going to help. It's definitely not going to hurt. So I would say carry on your whole life. And if people struggle to remember to take every day, I usually say try and remember once a week on a Sunday, but every day is better.
Thank you. So next one, I wanted to know how many CDA patients go on to have children?
Lots, and there's lots here with who've said they've got children. There's no link with fertility. You might need some help with transfusions during pregnancy, but yes, no problem with children.
Okay, so next questions. My question is, what are correlations between specific mutation SEC23B and phenotype?
I can answer to this. So we try to look at that. We also, and also Achille, Roberta. Indeed, there is no this very tight correlation. So we look for it, but in particular in CDA II, in the human, there is a very nice equilibrium with the expression of two genes, CDA and CDA and this probably this co-expression of gene may also alter a bit the effect of the mutation. So indeed, we look that more drastic mutation are really a bit more severe than the other mutation, but this is not so tight, so relevant. I don't know if Roberta agree in this.
Yes, I agree. I want to ask to add only one concept. You have to say that no patients with really disruptive mutations in the two disruptive mutations have been described so far. So this means that in presence of mutations, disruptive means mutations that reduce strongly the production of the protein. We have a tendency to a more severe phenotype, but as explained by Paola, there is an overlap between the patients with the different mutations. So there is no clear correlation between genotype and phenotype.
About these phenotype correlations, the more genetic testing we do, the more patients information we get from the patients, the more we get everyone together, whether it's in a registry. I see Roberta is nodding her head. The more information we can gather, the more we can help the patients in the future to say, we can put this information and we can learn from it and be able to answer those questions in the future.
Thank you. So next questions. I'm also an Italian CDA II patient. In my case, to avoid dependence addiction on transfusions, spilectomy was performed, and since then my quality of life has improved considerably. Could you please ask in English why people do not always choose to remove their spleen in case of transfusion addiction?
Achille.
Yes.
Yes, the spleen is a very important organ that is the site where the life of the red blood cell finish, but it's not the cause of this. So we demonstrated several years ago that if you remove the spleen in CDA subject, sometimes you could have an improvement, but this improvement is not a substantial improvement in the life because it's an improvement on 1 or at maximum 2 grams of hemoglobin. In the same time, you have all the problems that we now realize with a life without spleen. So you have to balance these two. It's better to have 1 gram of hemoglobin more. In certain circumstances, if this could be the difference between transfusion dependence and dependence, maybe the answer could be yes. But sometimes you could remove the spleen and without any substantial amelioration of the life, and also the substantial increase in the little increase in hemoglobin levels could also do not are lying along the life, but could end after 4 or 5 years. So now we have the attitude to not remove the spleen in the subject if not there is a substantial need for this. And so we have to examine each case, but in the vast majority of the cases, we do not suggest splenectomy in CDA patients.
Yes, we have to underline that this is something that changed in this past year, because in the past, this approach was different. So probably many adult patients had the spleen removed, but because in the past, this knowledge was not available.
I can go to the next questions. The prevalence of CDA has been described by my doctors as much more rare than you described. Here in the US, we were told 1 in nearly 100 million. Your figure was 1 in 1 million.
Yeah, in fact, I think it's more than 1 in 1 million. And the more we, the more genetic testing we do, the more cases we're finding. I think maybe the doctors that you speak to have seen only 1 in 100 million, but it's way more common than that. Akili, I think you want to add something.
Yes, because the clinical aspect of this condition are very heterogeneous, and we could think that we examine only the end of a mountain and not the entire CDA cases, but I am quite sure that a large number of CDA are not diagnosed through the life. So the true percentage of clinical cases of CDA must have much more. So if you consider, maybe these doctors consider only the cases that arrived in a clinics, so the transfusion dependence. If you consider only this, you could infer that the percentage is 1 in 2, 3, 10 million. But there are a lot of other cases that are not diagnosed, sometimes are confused in the adult life for cases of hemochromatosis.
Thank you. So next question is related to COVID-19. So COVID-19 has obviously been a major concern worldwide. Are CDA patients at a higher risk than the average patients, and why?
They're not. And we've done, in the UK, we've collected 700 cases of people with all types of rare anemias, so sickle cell, thalassemia, Diamond-Blackfan, CDA, etc. And we have very few CDA. They're not more at risk than anyone else. It's safe to have the vaccine.
Yeah.
Yeah. Even if your spleens was removed.
Okay, so I can go for the next one. Our doctor seems to think a simple ferritin test is adequate to check iron levels, but doesn't CDA cause iron buildup in organs? And would a simple blood test show buildup in organs?
Yeah, so with ferritin, again, this will probably depend on the country, but here in the UK, if your ferritin is over 500, we would do an MRI, T2 star MRI or a ferri scan. The only thing is if people have sideroblastic anemia, sometimes they can get iron loading with ferritin less than 500. But Achille and Roberta, I assume you see the same, that above 500 you would do a scan.
Yes,
Yeah.
yes. A lot of people with CDA, also with stomatocytosis or other condition, have increased ferritin level, but if you perform the T2 star, you could see that there is a liver iron overload that is not completely predictable using only the ferritin in the serum.
Okay, thank you. We know how CDA affects lifespan?
I've seen a few people asking this in the chat. There's no reason, CDA doesn't affect lifespan. There's no reason why the mutations would cause you to have a shorter life. Okay, it's not associated with cancer. It's not associated with a shorter life. But however, if it has to be well managed. So if you're transfusion dependent, the iron overload has to be looked after. So if you're on transfusions but you're iron overloaded and you develop cirrhosis, then your lifespan will be reduced. Or if you develop diabetes, your lifespan will be reduced. But it's completely possible, if you're well looked after and you look after yourself well, it's that whole teamwork thing I was talking about, to have a normal lifespan.
Thank you, Noemi. The other one is a comment, but I will share. I'm standing in for my husband who has CDA I. He was put on folic acid and vitamin B12. This improved his hemoglobin to just over 100, so he could stop desferal and be veninsected. He has been on B12 monthly and folic acid for 36 years.
Interesting. I've never seen that. Mostly the people I've looked after who've been vinisected, I've given them interferon. I haven't seen anybody who's vinisected from their hemoglobin from having B12 and folic acid, but that's great.
Is genetic testing, given the expense, worth pursuing if it won't affect treatment?
So I would say yes, absolutely, because what Roberta and Paola were talking about, sometimes you have the wrong diagnosis. You might think you have one diagnosis, not another. And also the more information we have. So for example, not everyone responds to interferon with CDA1, but the more information we put together, we might say, oh, look, all the people who have mutations in this part of the protein, they respond, and mutations in this part, they don't. And until we can gather all this information, we won't know. Yes. And also there may be new drugs, right? When new drugs come along, maybe the sotatercept, luspatercept, what if some people with a particular mutation respond or not? We don't know all this thing.
And I can also say that it is really needed because of the real and large number of misdiagnoses. When we look at a series of 100 patients followed for many years, and we went back to their history, and was really interesting that some patients changed. Also, this is a congenital disorder. They changed during their life two different diagnoses: Gilder syndrome, spherocytosis. This is sometimes we joke with this, but as much as we have information and as much as the diagnosis is precise, and now molecular testing can say the cause of your anemia is this one. So really, the cost or the possibility to do is really warranted.
Thank you. A comment with a question. It's interesting what Noemi said about folic acid. Our son is 8 and was advised to stop folic acid when he was 7. Is there a reason why it would have been stopped? Perhaps some test result that indicates he no longer needs it?
Maybe you're just feeding him lots and lots of broccoli and nice green leafy vegetables. That means that the blood tests for the folic acid always come back high even without the tablet. I would generally recommend to continue it lifelong, but we don't have evidence really.
Okay. So another questions on COVID-19 vaccines. Are there any concern for CDA patients regarding vaccination for COVID-19? A simple no. I see all of you saying no with the head, so I translate your expression, isn't it? Okay.
Mariangela, before to finish, I have to say something because about the therapy, because Noemi cited luspatercept that was just used in thalassemia for thalassemia patients and for other oncologic disease like myelodysplasia. But I have to announce that after 2 years treating with Celgene, we obtained the first trial, and we are ready to start with the first trial with the luspatercept in Europe. We enrolled patients from France, Germany, Greece, Turkey, and but I believe that it is very important that all the people could contact their centers to establish if they are eligible or not to this kind of therapy, because this could be a very important thing.
CDA 1 and 2?
CDA 1 and 2, yes.
Okay. Hi everyone, I'm from Singapore. I would like to check, is liver iron overload or heart iron overload worse? I had multiple transfusions during pregnancies and my ferritin test result have come back to be 900. We'll be doing a MRI in June to check.
So most people will load in the liver first and then in the heart. It's not true for sideroblastic anemia, but it usually is true for everything else. And it's hard to say which is worse because they give you different problems. But 900, it's good. At 900, it's good to do the scan, but I wouldn't be too worried until you get the result of the scan and you can make a plan from there.
Okay, thank you. Another question, is interferon A suitable for CDA 1A and 1B? Interferon suitable for...
At this stage, we would give it to either. We would give it to both, but I don't know whether Achille would or not.
Okay.
Achille, you give it to CDA 1 A and B?
Yes, the patients with 1A know since a long time that interferon could help, but in CDA B, I believe that there are only few treated cases to be sure of the results. But certainly, if needed, we could try.
Okay, so if I've checked properly the chat, there is one last question. We should have tackled all of them. I'm in the UK. I was diagnosed at birth. Can I request a genetic test again to see what mutation I have?
Yes. So in the UK, we've developed something called the genetic passport to make sure to tell the patients they have a right to know what's their genetic diagnosis, and you can always ask. So ask your clinician, and if they say you don't need it, tell them to email to Dr. Roy, and we will sort it out.
One last question. CDA I patients, is mandatory to do an exam for the heart, as same as the spleen?
We would do an echocardiogram every 3 to 5 years. Yeah.
Okay. The very last one. Should I take an MRI of the liver and heart? I only take MRI of the heart.
Usually it's the same scan. They do both analyses on the same scan. So I've never heard of anybody having just the heart, but you can probably ask them to look at the images and tell you the liver result.
Okay. So I think I am obliged to close the sessions. I'm sorry for that. Thank you to speakers for your presentation. Thank you for the audience for having shared your stories and your doubt and thoughts with us.